Hello everyone, welcome back to this short tutorial from Pathology Made Simple at ilovepathology.com. This is the part 2 of ovarian tumor series. In part 1, we had discussed about the anatomy and histology of ovary, and then we looked into the classification of ovarian tumors, right? In this part, we will be looking at surface epithelial tumors. We will understand the epidemiology and risk factors of surface epithelial tumors, and then in detail, we will try to learn serous and mucinous tumors, and finally, we will understand the differences between serous and mucinous tumors. Let's quickly recollect what we have learned in the previous session, right? So, we classified ovarian tumors into surface epithelial stromal tumors, germ cell tumors, sex cord stromal tumors, metastatic tumors, and then the miscellaneous tumors, right? Of which surface epithelial stromal tumors are the predominant type of tumors amongst all the ovarian tumors, which constitute around 65 to 70% of ovarian tumors. So, in this part, we will be looking at few surface epithelial stromal tumors. Now, what are these surface epithelial stromal tumors? As I told you, these are the most common tumors of ovary. So, among surface epithelial tumors, we need to know that most of these primary ovarian neoplasms are raised from Mullerian epithelium. See, there are different epithelial lineages in the female reproductive tract during embryonic development. Based on that, the surface epithelial tumors are categorized into serous tumors, mucinous tumors, endometrioid tumor, clear cell, and transitional cell tumors. The cells, or the lining epithelium of these tumors resemble that of fallopian tube in case of serous, endocervical epithelium in case of mucinous, endometrial, type of epithelium in case of endometrioid, gastrointestinal tract, and bladder in case of clear cell and transitional cell tumors. See, broadly, all these surface epithelial tumors are categorized as benign, borderline, and malignant tumors, of which benign constitutes the most common ones. They are around 60% of tumors are benign tumors, 5% are borderline tumor, whereas 35% of all epithelial tumors are malignant tumors. Even though it constitutes 35% of epithelial tumors, it constitutes around 85% of all malignant tumors of ovary. Okay, so the most common type of malignant tumors of ovary are surface epithelial tumors, ovarian carcinomas, right? Now, benign tumors, as the name says, there is no invasion, there is no atypia. Okay, they are bland looking tumors with bland looking cells and absolutely no invasion, then you call it as benign tumors. On the other hand, malignant tumors, meaning there should be unequivocal stromal invasion along with nuclear atypical features, cellular stratification, and mitotic activity. All these are features of malignancy. In between these two is the borderline tumor. Now, what is that? Borderline tumors, they don't have invasion, but then they have other histologic features of malignancy in the form of, nuclear atypia, cellular stratification, and mitotic activity can be seen in these tumors. So remember, benign tumors, no invasion, malignant tumors, invasion will be present, right? Now let us understand the risk factors for the occurrence of ovarian tumors. Nulliparity, infertility, late childbearing, and delayed menopause. All these are important risk factors for the development of ovarian carcinomas. So, what are the important factors which can protect an individual from developing ovarian carcinomas? They are oral contraceptive use, breastfeeding, and tubal ligation. Another important risk factor is if you have a family history of endometrial, breast, or colon cancer, then there is a possibility that ovarian cancers can occur because they might harbor mutations in the form of BRCA1 mutation or BRCA2 mutation. If anybody has these mutations, possibility of occurrence of ovarian carcinomas is around 20 to 60% by the time the patient attains 70 years of age. Apart from BRCA1 and BRCA2 gene mutations, there can be mutations of the DNA based mismatch repair genes. The most common ones are MLH1, MSH6, PMS2, and MSH2 genes, right? So remember that BRCA1 and BRCA2 are the most important genes which are mutated, which are risk factors for development of ovarian carcinomas. Now, we also need to understand, particularly when we talk about ovarian cancers, that is carcinoma of ovary, you talk about dual model of ovarian cancers where they are categorized into type 1 and type 2 ovarian cancers. Now, what is the difference between type 1 and type 2? Type 2 ovarian cancers are high grade serous carcinomas. Try to remember that type 2 ovarian carcinomas are high grade serous carcinomas. Apart from high-grade serous carcinoma, undifferentiated carcinoma and malignant mixed Mullerian tumors are categorized into type 2 ovarian cancers. Why are these important? Because these are the ones which present with advanced stage. They are rapidly progressive in nature. Whereas type 1 tumors, all the other ovarian cancers are classified or categorized into type 1 cancers. What are these other ovarian cancers? They can be low grade serous carcinomas, seromucinous carcinomas, mucinous carcinoma, endometrioid carcinoma, clear cell carcinoma, and malignant Brenner or transitional cell carcinomas are categorized as type 1. They are usually they present usually, when they are in early stage of cancer. They are slow growing and indolent tumors. So what you need to know now, the ovarian cancers are broadly categorized into low grade or type 1 and type 2. High grade is type 2, whereas low grade is type 1. Now let's move on to understand each of these tumors, serous tumors and mucinous tumors. Now what are these serous tumors? Which means these are the tumors with serous differentiation. Now what do you mean by that? These are tumors which are lined by the cells resembling those of the fallopian tube. Okay. There are four biologically distinct entities of serous tumors. One is serous cystadenoma or adenofibroma or cystadenofibromas. The second category is serous borderline tumor, which is also called as tumor of low malignant potential or atypical serous proliferated tumor. The third category is low grade serous carcinoma, and the fourth category is high grade serous carcinomas. Though there are four different entities, these are grouped into benign, which is serous adenoma, which accounts for around 50% of cases. Serous borderline tumor is around borderline serous tumor, and the last one is malignant, which accounts to 35% of all ovarian epithelial tumors, of which low-grade serous carcinomas accounts for around 5% of cases, whereas high-grade serous carcinomas accounts for around 95% of malignant serous tumors. Why is that we need to differentiate between low-grade serous carcinoma and high-grade serous carcinoma? Because the molecular pathogenesis of these two tumors are different. Low-grade serous carcinoma, there is mutations involving the KRAS, BRAF or ERBB2, whereas high-grade serous carcinomas, there is a high frequency of TP53 mutation. That's a tumor suppressor gene mutation, right? Almost all ovarian carcinomas which are arising in women with BRCA1 or BRCA2 mutations. We talked about risk factors, right? That is BRCA1 and BRCA mutations. If these patients develop ovarian carcinomas, they are almost always high grade serous carcinomas along with TP53 mutations. Now let's look into morphology of serous tumors. See, the benign tumors are the most common, as I told you. They are often unilocular. They are large cystic tumors, often unilocular, can be multilocular at times. Sometimes, you might find, papillary excretion within the cyst. Usually, the wall of the cyst is smooth, glistening. There is no epithelial thickening. At places, you might find some amount of papillary projections, whereas borderline tumors are the ones which contain increased number of papillary projections within the cyst wall. In contrast, malignant tumors are the ones which have large areas of solid no tumor, solid areas, papillary tumor growth, tumor irregularity. There is nodularity of the external surface. You might find areas of hemorrhage and necrosis. All these are features of malignant tumors. Now, coming to microscopical appearance, benign tumors, these are the tumors, as I told you, they are the ones which resemble epithelium of fallopian tube. So they contain, the cyst wall is lined by columnar epithelium. And remember, because I told you it's about fallopian tube, it should have cilia, right? So these cells retain abundant cilia, okay, and they are very microscopic. Papillae may or may not be found in benign tumors, whereas borderline tumors, you find that there is increased complexity of the papillae. Okay, So that's about borderline tumor. Where you do find stratification, there is some amount of mild amount of nuclear atypia can be seen in borderline tumor, but remember there is no evidence of invasion in borderline tumor, which is what differentiates it from malignant tumor, right? Whereas in malignant tumor there is widespread infiltration, there is frank effacement of the underlying stroma. Look at this. This is the stroma. There is effacement of stroma. There is invasion of these malignant tumor cells into the stroma. Okay, you find marked nuclear atypia. Look at the amount of pleomorphism you are seeing here. Marked nuclear atypia. Lots of these mitotic figures, pleomorphism, atypical mitotic figures. Sometimes you can also see multinucleation. So, say, look at this is a multinucleation. All nuclear features of malignancy are evident in the malignant tumor along with evidence of invasion, right? Sometimes some of these serous carcinomas you find concentric calcification, and these are called samoma bodies. So these are common in serous carcinomas. Almost serous carcinomas arising elsewhere in the body can also have these concentric calcifications, which are known as samoma bodies. Now, I told you low grade serous carcinoma and high grade serous carcinoma, right? See, both these tumors have the propensity to spread to peritoneal surfaces as well as the omentum. Where once the spread is into the peritoneal surface or omentum, then these patients manifest with presence of ascites. What is the prognosis of serous tumors? It is, of course, related to the histologic appearance of tumor, whether we are looking at benign tumor or borderline or malignant tumor, and also the presence and extent of peritoneal disease. See, the borderline tumors, they might cause no symptoms or they can spread very slowly. They might produce intestinal obstruction or other complications after many, many years. Low grade malignant tumors, as I told you earlier, they progress very slowly, whereas high grade malignant serous carcinomas are the ones which have very rapid clinical deterioration. The 5 year survival drastically comes down if at all there is a peritoneal involvement. These are the kind of patients who present with malignant ascites. They present with progressive loss of weight and cachextic symptoms. Okay, so high grade malignant tumors, if there is involvement of peritoneal surface, they show rapid clinical deterioration. So that's about serous tumors of ovary. We looked into benign, borderline, and malignant tumors. Moving on to mucinous tumors of ovary, they are less common than serous tumors, which accounts to around 20 to 25% of all ovarian tumors. Okay, most often mucinous tumors are unilateral, in contrast to serous tumors, which are often bilateral. In serous tumors, we had four entities, right? Whereas in mucinous tumors, we have only three entities. One is benign, that is mucinous cystadenoma or mucinous cystadenofibroma or adenofibroma. Second category is borderline category, which is mucinous borderline tumor, that is tumor of low melanin potential. The third one is mucinous carcinomas. Among the mucinous tumors, benign tumors are most common, accounting for around 80% of cases. The pathogenesis of mucinous tumors is basically these patients have mutation of KRAS proto-oncogene. Also, there can be loss of CDKN2A gene. So, morphologically, benign tumors, these are large tumors. They can vary from as small as 2 centimeter in size to as large as 30 centimeter. Almost always. Most often they are multiloculated tumors. They contain a very thick gelatinous fluid. Second category is borderline tumors, which can be larger than benign tumor. It's very difficult to differentiate benign versus borderline mucinous tumor based on the gross appearance alone. Okay, they both can look similar. Whereas malignant mucinous tumors, they have lots of larger solid areas. Morphologically, I mean microscopically, benign tumors, they have aligned. In this magnification itself, we can make out that there is multi-loculation, right? At low power magnification, we can easily make out that each of these, cystic spaces are lined by tall columnar epithelial cells with apical mucin. On the higher magnification, we can make out that these are very classical tall columnar epithelial cells with basally situated nucleus, benign looking nucleus. Okay, apical mucin, large amounts of mucin, and you don't find any cilia. Okay, in contrast to the serous tumors where you had cilia because that resembled what? Fallopian tube epithelium, whereas this one, they can mimic either gastric epithelium, that is the foveal epithelium, what you see on the stomach lining, or sometimes it can also be intestinal epithelium where you can find goblet cells in between. That is when you call it as intestinal mucous epithelium. Sometimes, it can also mimic endocervical type of epithelium, which is also a columnar epithelium with apical mucin, right? So they can be either gastric or intestinal or endocervical type of epithelium. But remember that there will be no cilia in these mucinous tumors. Borderline tumors, they have the similar kind of epithelium, but only thing is that you find epithelial stratification. It means there is increased layering of the nuclei. You find tufting of the epithelium with papillary or intraglandular growth. So that is the feature of borderline mucinous tumor. You don't find invasion. That's a very characteristic feature, right? If you find invasion, it straight away gets into the malignant ovarian tumor. You don't find invasion here. It looks like as if you're looking at tubular adenoma or villous adenoma, what you see in intestine. So, borderline mucinous tumors look like. Whereas malignant mucinous tumors or mucinous cystadenocarcinomas or mucinous carcinomas, they have a very complex growth pattern. Okay, you can at any magnification you can make out that there is widespread infiltration. There is frank effacement of the underlying stomach. Can you see that the tumor cells are seen infiltrating into the underlying stroma? Lots of mucin is there, broken glands, lots of cells with atypical nuclei, pleomorphism seen infiltrating into the underlying stroma. The one important feature we need to understand when we are looking at mucinous tumors is that there is an entity called pseudomyxoma peritoni, which is basically a mucinous ascites, which can be very extensive. Okay, you can also see those cystic epithelial implants on the peritoneal surfaces. They can cause adhesion, and these adhesions can cause intestinal obstruction as well, right? And frequently they are found to involve the ovaries. Now the question is whether it is arising from the mucinous carcinoma and then the tumor is sitting on the peritoneal surface. Actually it is found out that the source of pseudomyxoma peritoni is extra ovarian. Most often the source could be traced to the appendix will have the tumor, then there is pelage, and then you find lots of mucinous ascites as well as involvement on the ovary. Looks as if there is an ovarian tumor being spilled out onto the peritoneal surface. Finally, let us see the differences between serous tumors and mucinous tumors. As far as incidence is concerned, serous tumors are more common as compared to that of mucinous tumors. When we look at the ratio of benign and malignant tumors, 75% of serous tumors are benign, around 25% of serous tumors are malignant. Whereas mucinous tumors, 95% of mucinous tumors are benign, only around 5% are malignant. As I told you, serous tumors are often bilateral, whereas mucinous tumors are often unilateral. 20 to 50 years, more or less same. Usually, even the carcinomas, particularly when you're looking at serous carcinomas, they are more common in the younger individuals. Whereas mucinous tumors, they are found in age group of around 40 to 60 years. Molecular mechanism is also different. Serous tumors, they might harbor BRCA1 and BRCA2 mutation along with KRAS, whereas mucinous tumors, they don't have BRCA1 and 2 mutation. They are often KRAS mutation. Serous tumors are of moderate size, whereas as compared to that of mucinous tumors, because mucinous tumors can be very, very large and can be heavy also. Serous tumors, as I told you, they are most often unilocular. Sometimes you can find multiloculations, but then by and large, serous tumors are most often unilocular, whereas mucinous tumors, almost always, they are multilocular. Very, very rare to find a unilocular mucinous tumor. Serous tumors contain serous fluid, very thin fluid. Sometimes they can be a viscid fluid, whereas the mucinous tumors have thick and gelatinous fluid, right? Lining epithelium of serous tumors, we know that they are lined by columnar epithelium with cilia, whereas mucinous tumors can be lined either by gastric or intestinal or endocervical, but then you don't find cilia. Papillary projections are more common, are very common in serous tumors, uncommon in case of mucinous tumors. These are the general differences between serous and mucinous tumors of ovary. So with this, I have completed serous and mucinous tumors, and then we understood the differences between serous and mucinous tumors of ovary. In the next session, we will discuss endometrioid tumor, clear cell tumor, and Brenner tumor, and then we'll move on to understand the general features of ovarian epithelial tumors, the prognosis, the treatment aspects, and if we can, the preventive aspects of ovarian tumors. Right? Stay tuned for the next tutorial. So that's it from my side. If you have liked this video, hit the like button. Do comment if you have any queries to ask. Don't forget to subscribe if you find this video useful, and please do share so that somebody else can benefit from this. Thank you.